Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Hi, I'm Dr. Timothy Murray, and I'm welcoming you to JVRD's Author Podcast, where we have the opportunity to discuss some of our key manuscripts. We're joined today by Dr. Jose Echegaray from the Retina Consultants of Orlando. They had a unique case presentation that was published in this month's journal, and we're going to spend a little time talking about that presentation. Dr. Echegaray, thanks for joining us.
Thank you, Dr. Murray, for inviting me, and it's a pleasure to be here.
So you had a very unique case. Your case title is Resolution of Anterior Uveal Infiltration of Acute Lymphoblastic Leukemia after Chimeric Antigen Receptor T-cell therapy or CAR-T therapy. Can you tell me a little bit about how you were first involved with this patient?
Sure. So this was a patient with a known acute B-cell lymphoblastic leukemia who presented to our clinic, actually presented to a general clinic with a hypopion, thinking the thought was that she had just uveitis. She was then referred to our clinic already on prednisolone drops. When she got to me, the hypopion was gone, but because of her known history, I suspected there could be some relapse here. We sent her over to oncology. She did show to have systemic relapse with a bone marrow biopsy. And she was then at that point placed on chemotherapy. 6 months after that, she comes back to me with eye pain and loss of vision with the full-blown infiltration of the iris, neovascularization, cells, hypopion. And that's when we got really involved as ophthalmologists.
Jose, when you see this patient, I think there's a couple key points. You mentioned hypopion, which makes everyone think of something infectious. But this is really, are we assuming a pseudo-hypopion, which is an infiltrative process? And how did you distinguish that?
That's correct. So I feel that the hypopion, the pseudohypopion, which is, of course, related to a malignancy, is more of a cleaner type of infiltrate in the anterior chamber without the flare that we see associated in uveitis patients, without the KPs necessarily, and other atrophic changes that you can see in other tissues. It's more like a cleaner white infiltrate kind of settled in the anterior chamber.
The other thing you mentioned was that the patient was treated with steroid therapy initially and had a significant resolution. And of course, that's one of the key points we look at in a hematologic malignancy that involves the eye.
Correct. Within 24 hours of starting the patient on initial prednisolone, those cells were gone. And so when I saw the patient, it was just, too good to be true for that significant of a uveitis type of syndrome.
And then now the patient gets managed and comes back, but what we're suggesting is that the eye remained infiltrated throughout the process, correct?
Correct. So that's the assumption. And then 6 months after initial presentation, it was a full-blown uveal infiltration, which is not the most common manifestation of leukemia in the eye. As we know, leukemia usually shows up with more of a vaso-occlusive manifestation in the retina, but not commonly as a uveal infiltrative disease. So that was, of course, concerning. And so we moved on with a biopsy of the aspiration biopsy of the anterior chamber and also of the uveal tissue. And that allowed us to continue to guide this patient towards eventually CAR-T therapy.
So I think that's important too, because many times I'm comfortable with the clinical diagnosis, but when we turn to our medical oncology colleagues to treat, they are very picky, particularly lately, of really wanting, a tissue or cellular diagnosis. And so you were able to get that for them, which clinches the diagnosis. So now bring me up to CAR T therapy, because there's been some discussion about whether CAR T therapy would be effective in an immune privileged area like the eye.
Correct. So once the patient showed the second relapse within a 6-month period, and we proved to the oncology crowd that there is infiltration in the eye, then we were able to present this in a tumor board symposium. And the decision at that point was to move ahead with CAR T based on, number one, the fact that this was a refractory case. And we know that one of the main indications for CAR T is for refractory cases. And number two, because the immunologic panel of the surface antigens of the cancer cells showed CD19 positivity, and that allows for CAR T to be an option in this case. So, we had that discussion, and we decided to move forward. And, we were happy that we were able to contribute, because we as ophthalmologists, we can see the tissue directly, different than other physicians in medicine, where they rely on more MRIs or CT scans sort of imaging modalities. We are able to see the pathology right there.
And I have a hard time actually sometimes negotiating with my medical oncology team, because they're like, well, we don't see it on the MRI. And I'm like, of course you don't. The tissue is so small, the involvement is focal. We can see things that they do not see. And there's where ultrasound also for ophthalmic ultrasound can be helpful, as is anterior segment, OCT and UBM. So great case. You also had discussed that prior to CAR T therapy, alternative treatment strategies were radiotherapy and continuing or altering systemic chemotherapy, correct?
Right. So in this case, we thought that CAR T would be a good opportunity to attempt this in this patient, because it was already refractory to chemotherapy. And it's a way also to spare them from radiation, which we know that it works for these lymphoproliferative diseases, but it is, of course, in many cases, used more of a last resort, especially when it's more of a unilateral disease. So we were fortunate that we could count with the CAR T team, and the patient did very, very well, 20/20 vision at the end, and has been on remission since.
Yeah, so you had a good extended follow-up, excellent visual and anatomic outcomes. Really can't be a better result than that. One of the things, though, that your patient did experience with the CAR T therapy was some of the complications associated with CAR T. So I think we need to reiterate to people that are less experienced with these treatments that they do have some significant impact when patients have a complication like that.
Yes, in our patient, that limited our ability to provide further treatment cycles. So we only could use one infusion. So when we do CAR T, initially the patient is lymphodepleted. So you take the patient's lymphoblast lymphocytes, and that the patient undergoes a cycle of cyclophosphamide. So we know that is a very delicate medication systemically for patients. And then once you insert the artificially constructed T cells, they go back into the bloodstream. They can cause cytokine release syndrome, which happened in our patient, and other neurotoxic side effects. In addition to, in some cases, you have reports of uveitis also as a secondary effect as well when it comes to the eye. So this is not without any possible side effects, and the patient has to know about this and should be informed.
I think you have presented a fascinating case, and you discussed it well, and it has so many important clinical pearls that we've talked about tonight already. So thank you very much. Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.